Thank you everyone for joining us. My name is Britta. I work at the Coolidge Corner Library here in Brookline. I really wish we could be together in person, but the library has been offering virtual programs for a full year now. And we have found one of the silver linings is that you don't have to be from Brookline or travel to Brookline in order to participate. So no matter where you're joining us from, if you'd like to keep up to date on our programs, I would invite you to sign up for our library newsletter. And you can go to brklib.com/newsletter if you'd like to sign up. Please feel free to interact today in the chat. You can also type questions into the Q&A, which is found at the bottom of your screen. And we'll take those towards the end of the program. We are recording today and broadcasting live thanks to Brookline Interactive Group. So I won't connect your name to your question unless you specifically request it. And now I'd like to introduce today's panelists. Caitlin LeVake is a pediatric nurse practitioner. She earned her undergraduate degree in biology from Providence College in 2005 and her master's in nursing from Simmons University in 2009. She has been full-time faculty with Simmons Online School of Nursing since 2016. In addition to teaching, Professor LeVake maintains a small but busy pediatric primary care practice. She has a strong interest in preventative medicine, particularly vaccine practices and education. Meredith Troutman Jordan earned a PhD in nursing from the University of South Carolina and has taught psychiatric nursing for 18 years, currently also at Simmons. She has experience with care of individuals with psychiatric illness and addiction and home health care of older adults with acute and chronic psychiatric illness. As a Quality Matters certified master reviewer and facilitator, she ensures the rigor and consistency of the peer review process for certification reviews of online courses. Jacqueline Luddy is a project manager for the Mass General Hospital Center for Telehealth. She works in business development, focusing on virtual consults with externally facing entities. Prior to this role in the center, Jacqueline worked in the virtual visit space of telehealth as a project manager for the virtual visit program at Mass General. Jacqueline holds an MBA with a healthcare concentration from Suffolk University. Rachel Berger is also a project manager for the Mass General Hospital Center for Telehealth. She works on a variety of projects, including the implementation of virtual consult programs and managing development projects for the MGH Telehealth portal. Prior to Mass General, Rachel worked at the Harvard T.H. Chan School of Public Health in Executive Education and at Avant-Garde Health. Rachel holds an MHA from Suffolk University. So welcome to all of you. Thank you so much for joining us this afternoon. And I'd love to start by just asking you, I know I've just introduced you, but if you could tell us a little bit more about what you do or what your institution does and how it relates to telehealth. And I will start with Caitlin.
Sure. So I'm a pediatric nurse practitioner in a small primary care office in Southern Rhode Island. Is a 3-provider practice. It's myself, another nurse practitioner, and a pediatrician. And I also teach at Simmons in the nurse practitioner program. But for us in our practice, I think we were very comfortable with telephone health in pediatrics. We manage a lot of developmental questions, nutrition questions over the phone, and that was standard for our practice. We also do a lot of nighttime triage for illness and fevers, and we were very comfortable with that. But I think over the past year, we've had to become much more comfortable managing our chronic illnesses via telehealth or our mental health via telehealth. So that's been a change for us over the past year.
Thank you. Meredith?
Well, I was going to share that I maintain my, I teach full time, and I do a volunteer service one day a week in a local, I was in a local clinic in the Charlotte, North Carolina area that provided social support, resources, assistance with finding employment, housing for chronically mentally ill people, many of whom are people who are dealing with homelessness. And they really were, it was like being in a car accident and coming to a screeching halt when COVID hit, because delivering services to these individuals, many of whom, as I said, had chronic mental illness, was a real challenge. So what we began to do was delivering interventions online. So they had educational offerings, for instance, how to develop a resume to get a job and things like that were available via Zoom. So assessments was possible to continue to do to some extent for those folks, and maybe recognize risk factors or the need that somebody needs to be connected with their social worker or case manager if they had one to be transported to a facility. But it's been a real challenge. We've made some progress since that time, but it remains challenging in large part because the population, like I said, is chronically mentally ill, many of whom are homeless and don't have access to technology to be able to continue to receive services.
Okay, thank you. That's a population that we in public libraries have also been extremely concerned about, so I can relate.
Yeah.
Thank you. Jacqueline?
Hi, Jacqueline Luddy. As Britta mentioned, I'm a project manager in the Center for Telehealth at Mass General. And in the Center for Telehealth, we really have three major components that we work on. The first being virtual visits, which is, I think, probably the most popular of telehealth services. That is a direct provider to patient service, typically done through a platform like we're using now via Zoom. But we also have a couple of others, so virtual consults, which is a consultation typically done between provider and provider, and it's with Mass General physicians to an outside institution. So, for example, our flagship program, the IntelliStroke, is, if a patient presents with a stroke to an outside community hospital, that community hospital has the option, if they have a service with us, to reach out to that Mass General physician and get the clinical services needed for that patient there. We also have inpatient telehealth programs, which Rachel may be able to speak to a little bit more, but are fairly new with the coming of COVID, but really meant to help patients that are currently inpatient at Mass General communicate with providers as well as with family members. So I started in the Center for Telehealth working on virtual visits. My first 6 years there focused on that, and have recently transferred over to more of the virtual consult side of the telehealth world.
And Rachel.
Thanks, Britta. So I work very closely with Jacqueline in the Center for Telehealth at Mass General. She gave a good overview of the various virtual care services that the center does provide. My work specifically as a project manager is to work on optimizing our virtual consult workflows and enhance our capabilities for virtual care through technology.
Wonderful. Okay, great. Thanks, everyone. So I want to rewind a little bit because, as some of you have already hinted, telehealth did not just pop up out of nowhere in 2020. It's been around for a while in various guises. So I wonder if you could review some of the history of telehealth and describe sort of where the landscape was prior to the pandemic. Shall we go in the other direction? Rachel, do you want to start us off?
Sure. Jacqueline can probably speak a bit more to the history of virtual visits, at least within Mass General, but virtual consults specifically, which is the workflow Jacqueline alluded to earlier, which is a physician at a community hospital gaining access to the expertise of an MGH specialist by engaging a phone or video call, has actually been around at Mass General since the 1990s when we launched our telestroke program. So we've actually been running that virtual program for about 30 years now. So it's been quite a while in the making, and technology has obviously really ramped up and increased what we're able to offer. But that program has been around for quite some time.
Yeah, and so for the virtual visit program at Mass General, it was started in 2013. So we started with just 2 clinical services, which were psychiatry and neurology. And at that time averaged about 10 visits a month. 10 visits a month was a successful month for us. Over the last 7 or 8 years, it has, even pre-COVID, was continuing to grow pretty steadily. right before COVID hit in late February, we were averaging about 1,000 visits per month. And I think at that time we were up to about 15 clinical service areas. And then, the world, the world changed as we know it. And, between the months of March and August, we were up to 440,000 virtual visits. So averaging, more than 70,000 visits a month in that COVID period. So quite an increase.
Yeah, my goodness. Yeah. I'm curious too, it seems like Mass General is kind of out ahead, well, in so many regards, but in this space in particular, is that accurate to think that over time they've been sort of a leader, and that maybe a lot of other hospitals would not have seen that type of activity prior to last year?
Yeah, I think prior to COVID, we were definitely one of the leaders in the virtual visit space. And we were really lucky to have the infrastructure and the team that we had when COVID hit. I think a lot of other hospitals, across the world, across the country, we're scrambling to try and get this figured out. So I think we definitely considered ourselves very lucky to have what we had in place when COVID hit.
Speak a little bit to the use of technology pre-COVID. When I had a student group at a hospital for a good 10 or 15 years prior to my current position, we oftentimes would see particularly children and adolescents who would report to this inpatient hospital, who would report to the emergency department having psychiatric symptoms, and it was difficult to find someone to see them, someone that was available, and when they were looking for placement. So technology became, I think, increasingly used prior to the onset of COVID, where a visit would be done virtually. So the child's there in the emergency room. They need to be seen by a psychiatrist. This facility did not have a psychiatrist 24/7. So a virtual visit was done. So the interview and some assessment data could be collected that way. So in that regard, that particular facility, they were taking some steps towards use of telehealth pre-COVID.
I'm in a different position in that my first experience with true virtual visits, computer-based visits, really has been over the past year. As I said, I did a lot of telephone health, but this has been a change for me as a provider over the past year. So I've been trying to learn as rapidly as I can to keep up with the times.
Right. Well, that kind of leads right into my next question, because as we did hit a year ago, it seemed like the entire medical field had to really swing into action with telehealth with very little warning. And I wonder if you could talk a little bit about what policies you had to sort of update or implement, what resources were needed, and what strategies were used in that incredible pivot that we saw. Caitlin, do you want to start us off with that?
Sure. So in our practice, we did see patients throughout the entirety of COVID, really because our youngest patients, particularly our newborns and infants, really do require that physical exam. So we really prioritized our visits to see those that we truly had to see in the office. We did a lot of rescheduling of well visits in the beginning because we just were unsure about what to do, and we didn't have the capability to do the virtual visits last March. We did work with our electronic medical record company, which is eClinical, who kind of came on and helped us to establish virtual visits through our EMR. So it's been a challenge, and in terms of implementing policies, we really had to work through those. We were very informal to begin with, which I think many places were, and then we've formalized our policies over time as we learned more about telehealth. I think most importantly, telling our patients when a visit is considered a telehealth visit is important. So when we book patients for appointments, our staff is very clear about saying this will be a telehealth visit. And then making sure, there's a lot of other things that go into that in terms of billing and coding for those visits that we've had to learn over time. Mm-hmm. But I've really grown to love telehealth for certain visits. I think are very, very effective.
I'm going to throw it to you, Jacqueline.
Sure. So I think, like I just said, MG, we were in a good spot, I think, technology-wise and personnel-wise, but we were in a good spot to manage 1,000 patients per month, 1,000 visits per month. So when this hit, their hospital activated their HICS, which is the Hospital Incident Command Center, which really was able to help our team tremendously. So it pulled in various roles across the hospital, from ambulatory management, from eCare, our electronic health record system, IT, everyone. It was an all hands on deck situation to really make sure that we were going to be able to deploy these types of visits hospital-wide, because the majority of the Mass General Hospital outpatient visits were switched to virtual fairly quickly. We were also in the midst of a technology transition. So that was, a little, that was fun. But, we can't say enough about all of the teams at Mass General coming together. There was a labor pool that was put together where, folks whose, traditional role may not have been as busy, they were pulled in to help our team to really make sure that we could give this access to as many patients as possible to make sure folks were getting the care that they needed during that time.
Rachel, did you want to add it? Yeah.
Sorry, I can just add a bit more about what we saw in terms of policy shifts during that time as well. When the state of emergency was declared last year, we did see restrictions being lifted on a few different fronts to allow care to continue in as many ways as possible. A few examples of that are the out-of-state licensing requirements, as well as relaxed guidance around HIPAA enforcement when using these virtual platforms. At the beginning of COVID, it was really see patients how you can, and if that's over FaceTime and the alternative is that they wouldn't be getting care, then we would want to see them however we could. Probably the most meaningful change that we saw in terms of policy was implementing payment parity for virtual care, which means that in some cases, a virtual interaction between a patient and their physician will be reimbursed the same way as if they were actually together in person, which is very different than the case before COVID. So it really equipped hospitals to be able to deliver care quickly and without fear of retaliation, and then also just making sure that they will be reimbursed for that work that they're doing as well.
Meredith.
I couldn't hear you.
I was just wondering, did you have anything to add on this one?
Oh, well, I had been thinking more in terms of from a faculty perspective and from an education perspective and working with the students. And one of the things, that my students have to do, and one of the courses I regularly teach is a family theory course. So we had to talk with them, coaching them through how to deliver, how are you going to deliver telehealth? How is your job changing? What kind of strategies are you going to have to implement to successfully complete this course? And one of the things I have to do in the particular course I'm thinking of is they have to conduct an in-depth assessment with a family. So some of it was coaching them for how to conduct your community health nursing assessment. And some of them, may or will end up working in home health or various community settings. So it was my experience from a provider perspective was in terms of coaching them and building their confidence in their ability and thinking creatively for how to connect with patients in order to complete assessments, do patient education, et cetera.
All right, great. And I definitely want to hear more about that. I did want to follow up. I used the sort of euphemism resources in that question, but I am curious if any of you have experiences with money specifically. And, Rachel mentioned reimbursements, but in terms of did clinics and hospitals get support for actually implementing, the costs of technology and training and any of that? Or did you get state support, federal support, or just have to pull it together as best you could?
We did receive some monies from the state of Rhode Island to help support implementation of telehealth in our practice, and from some of the insurance companies directly, which was very helpful. And I think just supporting the visits, like Rachel was explaining, and that we were being reimbursed for those visits was very helpful in order to establish a good telehealth setting within our practice.
I think outside of the reimbursement, I'm not too sure what Mass General or the larger organization, Mass General Brigham, if they received any additional support, but I will reiterate that the reimbursement for these visits was huge, because pre-COVID, that was really one of the biggest barriers that we saw with telehealth visits.
All right, thank you. So I did want to dig in a little bit, since we have two professors with us, into how future providers are being prepared for telehealth practice, and how that differs from what you were teaching and coaching beforehand. And I'm also interested in how that kind of education differs from how current, already practicing providers were educated and trained to make these changes in their current practice. So Meredith, do you want to pick up where you left off with that?
That is an excellent question. And in fact, I can answer that fairly clearly. After or in response to, subsequent to the dramatic shift to online everything with the onset of COVID last year, I began to think more and more, and in reflecting on, for example, at the time where I was teaching a clinical group of psychiatric nursing undergraduate students, and so clinical was completely shut down. We could not have students out in the community or even in hospitals working with patients and posing a risk to those students. So we had to rely on virtual clinical experiences. And I'm certain that it lacks in medical nursing, but it certainly lacks in psychiatric nursing, because an avatar is just not nearly the same as interacting with a real human being. So we really had to strategize, and I worked to really make as much contact and face-to-face interaction that I could with students, and also trying to build their confidence, their self-efficacy related to use of various technologies. I don't know how many, it will be interesting in retrospect, how familiar people were with, or even having heard of Zoom prior to COVID. Those of us who were Simmons instructors were very well versed and very skilled with Zoom. I don't think it was even a bump in the road for us. I'm not sure that it was the same for nursing instructors outside of, or perhaps those who use other platforms. But in that regard, I don't think it was even like I said, a bump in the road. What I have found is that I've talked more in students as far as, how are you actually delivering the care beyond what we're teaching you, and how we're teaching you via Zoom and virtual connections in the classroom. And so in thinking about those experiences, I have developed a couple proposals, one of which is still under review, to get funding to support inclusion of telehealth in nursing programs, or in a nursing program for education. And in preparing that proposal, I did an extensive review of the literature, and telehealth is very minimally included in schools of nursing. It could be different now, several months down the road from when I did that initial literature review, but it's not very adequately covered. And one really good source that I found was very useful. It identified and talked about telehealth competencies, but even that source was rather outdated. So there'd been a gap in time, and not much that had been done to advance what we know about, or what we're teaching students about telehealth since the initial publication. And that, I think, was 7 years ago.
Wow. Yeah. Do you envision, in thinking about how it might be integrated into nursing education, do you see it as sort of its own, you take a course on telehealth, or would you prefer to see it integrated as an aspect to every course?
I think it would be much stronger, much more effective if we integrated it throughout each course, because telehealth could be utilized in pediatrics, psychiatric patients. I remember even when I was in school years ago, home monitoring for prenatally, whatever the gadgets they use to detect movement, fetal movement. So there's a number of different ways in which telehealth could be utilized. So I'm not sure that it would really meaningfully be able to be shared or students be exposed to if it were just within one course, because there's such diversity in the ways one could use telehealth across different specialties, for example.
Okay. All right, great, thank you. Caitlin?
Sure, so I teach the advanced health assessment course in our program, and I have always told students that 90% of your diagnosis is in your history. So the focus of my class is really helping students to take an excellent history, which I think is so important for telehealth because that's what you're limited to most of the time. I know that there are some things that we can do to aid in our physical exam with virtual visits, but if they can take an excellent history, they're almost there in terms of telehealth. So that's the focus of our class. And we have started talking about that. How would you do this if this was a virtual visit? Although we don't have anything built into the course yet, specifically to virtual health or telehealth.
Thank you. Jacqueline, Rachel, do you have anything? I wonder if you have any insight into the continuing medical education angle in particular.
Yeah, I will just share that telehealth is becoming more kind of baked into the residency program at Mass General versus in the past it may have been more of an elective or optional component. Now, when the residents are observing a clinic, it may be in person, it may be virtual. It's really just kind of a, that's the day-to-day operations now. So it's really is integrated, as Meredith was mentioning, in the rest of their education in various forms as well. So the virtual visits, but also the virtual consults program that we've been discussing as well.
And I'll just add, I think within our team and the Center for Telehealth, we do have a few team members who focus strictly on research and education for telehealth. So I think, hopefully we're hoping in the coming months to really start to dig deeper and do some work into how we can incorporate, the vast variety of telehealth options that are out there into the continuing medical education that providers are currently doing today.
Great, thank you. So I have this question that actually an attendee has already asked as well. So I think this is a big area of curiosity, which is what specialties are particularly well suited to telehealth and maybe which are poorly suited. And Meredith, I would love if you could speak to the specific needs of mental health in particular. Actually, do you want to start us off?
I would be glad to. I think there's certainly lots of potential as far as willingness and general self-efficacy, comfort with use of telehealth. If we could just get people to have that technology self-efficacy, if you will, if we can get them set up. I think most patients, and we've not experienced any barriers with the distance assessments that have been done, or offsite assessments that have been done in the emergency department that I described a few minutes ago. However, that being said, those individuals being assessed by a provider offsite are assisted. There's the computer placed in front of them, so they're not having to deal with or navigate that technology. Although they were receptive and willing to cooperate with the process. The challenge that I've seen more so even than the psychiatric patient is the older adult patient. And some of my service involves board membership for a couple local organizations that provide. So one is the Senior Center, one is Arthritis Patient Services of Charlotte, Mecklenburg County. And those have been more challenged because we can deliver education, health education. And actually, I think it's amazing that they've done some exercise groups that they've delivered via Zoom. So they've been able to continue some of the programming for those individuals, but it's still been challenging because many of those folks just do not use technology. So if you don't use a computer or don't have a computer, you can't access the email newsletters that the Senior Center is sending out, or the exercise classes that Arthritis Patient Services is delivering, or the educational programming that's delivered from either of those via technology. So very simplistic telehealth, but one thing that the Senior Center has been doing is they do the robocall. So every week, because I'm on their board, I get one of the calls that, hello, are you okay? We've got these events upcoming at the Senior Center, and at this particular center, periodically they'll have drive-throughs. So they roll the carts with the books and the puzzles out there, and people can drive through and pick up a back lunch or whatever social activities or books that are available. So I think those things have been more received than than responses to email messaging that's been sent out. I'm not sure the attendance or the participation in the virtual exercise or the psychoeducational classes that have been offered, but that is one thing that's available for those who can and will use it.
All right, great, thank you. Caitlin?
Yeah, I can go ahead and say for me, it's not, I would say, so much the specialty, but it's the age of the patient and the chief complaint that they're there for. So for me, many of my patients are nonverbal because they're infants or young toddlers, and that can make a visit very difficult, particularly when you have a parent that's bringing a child in because they just seem off or they're fussy. So they don't know, the child can't explain it to me. And to get a 1 or a 2-year-old to sit still on a computer screen is very challenging. And then at the other end for me, my adolescent patients, what I think is limiting for me is that we can't really maintain confidentiality for those patients because there's often very well-meaning parents that are there in the background with them. And that can make it challenging in regards to mental health concerns, sexual health practices. So those are the visits that I find very difficult to manage via telehealth.
I think, as far as specialties that are not suited, I'm not sure that there are any. I think there are definitely types of visits, that, like Caitlin mentioned, that are not the best for telehealth. But one thing I will mention is not specifically related to the clinical specialty, but I think types of visits, right, that are suited, I think, really well for telehealth, particularly multidisciplinary visits. So if you have a patient who needs to see a doctor, a nutritionist, or they're a primary care physician and a specialist, oftentimes it's a lot easier to coordinate those via telehealth visits than it is to come into the office. And I think patients really benefit. I'm sure providers do as well from being able to have that group visit via telehealth. Also patients, that have mobility challenges, when a caregiver needs to be involved, especially in these COVID times, immunocompromised patients, telehealth really is beneficial for those folks to not have to travel into the hospital or to be able to have a caregiver involved without taking time off from work or having to find childcare. They really find telehealth to be beneficial for those as well.
And Jacqueline, just to go off of that, I would completely agree. For an example of some of my patients with Down syndrome, we don't have a Down syndrome clinic here in Rhode Island, but you do in Boston. So our patients will go there and their access to care has increased tremendously because they can do those multidisciplinary visits from home. So it's been a wonderful change for those patients that have complex medical needs.
Mm-hmm.
Rachel, anything to add there?
Oh, nothing else from my end.
Okay. All right, great. Okay, so we have a couple of nursing pros here, obviously. So I'm wondering if there are specific needs and concerns of nurses that differ from those of doctors. And I realize there are many different types of nurses and many different types of doctors, so that's a hard one to answer. But if you can make any generalizations there.
Well, I'm going to be biased here in my response. And I was thinking about this and having this a conversation related to this just with someone just yesterday. In fact, I think it was in class. I was reinforcing to the students that we as nurses treat or address the human response to illness or actual or potential illness, whereas physicians deal with illness and disease. And so in my assessment, I would say that we have a much broader approach to patients, as well as oftentimes their families, and communication is so important. Further, as for I don't know how many years now, nursing has been recognized as the most trusted profession in polls. So I think we can use telehealth we can be strength focused with our use of telehealth and the fact that we are recognized as a trusting, caring profession. So I think there's great potential there. I would think that perhaps it's even more critical and maybe in some instances challenging for nursing to make use of telehealth because we are having a broader approach to that patient, not just what's going on with regard to a physical assessment, but how that patient feels about that. Is it distressing? How it's interrupting their daily routine, their ability to relate to their family members. So I think there's some challenges that perhaps nursing is more sensitive to than medicine or other providers might not be aware of or addressing or thinking about as readily. But I think that just further highlights the importance that we begin to increase telehealth content within our nursing programs.
Absolutely. Caitlin, did you want to comment there?
Sure. For me, clinically in my practice, I can't see that my needs or concerns differ than the physician that I work with, but I would imagine geographically, depending on which state in which you practice, that may differ. I'm in an independent practice state as a nurse practitioner, but some states are not. So maybe
Right.
I would suppose that would be different. Yeah.
I will share as well that outside of the virtual visit interaction, kind of a standalone appointment, our inpatient telehealth programs at Mass General are really catered to meet the needs of bedside nurses who are doing that ongoing care for hospitalized patients. So in that program, an iPad is set up at the bedside of the patient and can be called into if the patient has a question or if nurses want to check in without actually needing to go to the room and enter the room every time they want to interact with that patient. So we found that to be very beneficial for patients who are on COVID precautions, and really helps nurses kind of maximize the time that they're spending traveling between rooms, gearing up in PPE, and needing to enter that room on every occasion.
Okay. So I wanted to ask if you think there are aspects of a patient-provider interaction that just cannot be reproduced in the virtual environment. And I'll just insert here that as I've been telling people about this program leading up to it, I get this reaction a lot that, people say, oh, telehealth is great, technology is great, but it's just not the same, and I think what a lay audience thinks of as bedside manner really is a concern of a lot of people. So Jacqueline, do you want to start off with that one?
Sure. Also just note, the bedside manner, we've started talking about website manner, right? Like it's important these days for providers all like to have that website manner with their patients. So it's a learning curve, I think, but exciting. I mean, not being a provider myself, I think some of the things that come to mind for me, if there's a physical exam needed, you need to come into the office. We're not going to be able to do that for you over telehealth. So certain testing, so labs or an x-ray, ultrasounds, again, I think telehealth lends itself really well to learning the results of those testings, but for the tests themselves, you will still need to come into the office. Vaccinations, I know from a personal situation, some of my children have had to go into the office, which I'm sure Caitlin can speak to better than I can, because they need vaccines. And again, you're not gonna be able to get those things via telehealth.
Caitlin, did you want to?
Sure. I suppose I could say that maybe I'm being selfish on my part as a provider, but there are pieces that I really miss. Holding a toddler, holding an infant, hugging a postpartum mom, hugging an adolescent that's struggling. Those are parts that you just can't replicate, I think, in the virtual setting. And part of me as a provider is not feeling fulfilled because of that and because I miss that, but it's coming back and I think things will get better. But those are the parts that I miss, I would say.
Meredith?
I would echo or build upon what Caitlin has shared. And I was thinking of somewhere that I had read recently within the past few years about how many older adults, particularly those in long-term care facilities, are never touched beyond assistance with ADLs if they need assistance with hygiene. And so definitely in building upon what she said, I think probably providers and most likely patients or residents in the case of long-term care, whether they acknowledge it or they're aware of it or not, have missed that physical contact. And as we know in psychiatric mental health, a tremendous part of communication is nonverbal communication. So we cannot get that touch via the screen. And I wonder how many other things that we're missing on the screen, other things that we might not be able to see. I think about tremors in patients' hands, and even at best you could probably look, but if you're trying to assess, for example, the very fine tremor that's present when someone is withdrawing from a medication or maybe having a side effect of a medication, that would be really challenging to be able to assess, as well as other common side effects of many of the psychotropic medicines. So, it has its benefits. It's better than, like someone said, nothing. at least we have a visual to put without audio from that patient, but there's still tremendous limitations. And like I said, the first thing that comes to my mind is assessing patient response to medication, including adverse effects.
Rachel, did you want to add anything?
Oh, I think Meredith really hit the nail on the head there, especially, you know, with saying it, like anything, it has its limitations. In some scenarios when it's, you know, sharing lab results and it's saving a patient needing to drive into MGH and finding parking and taking the afternoon off work, you know, it can really have a lot of benefits in that way. But of course, the in-person experience can never be completely replicated online.
All right, so we've already touched on this a bunch, but I do want to specifically ask about disparities in access. And I know a lot of these are tied directly to access to technology, but how race, age, economic status, and geography show up in telehealth, and if there are ways in which those disparities can be mitigated. Rachel, do you want to start us off this time?
Sure. I would say, of course, probably the most obvious barrier here is access to technology. So having a device, having a reliable internet connection, having a webcam built into your device, and also a place where you can privately and securely conduct your visit. Those are all things that many people don't have. And that's, you know, what's required for a high quality virtual visit. So, you know, there are ways that we can think about mitigating some of those factors, but also just gaining access. And I'm thinking a lot about what everyone's been talking about, how difficult it's been to schedule vaccine appointments. And it really highlights in these older populations how difficult it can be to, you know, log in and do these things that for younger people or people who are used to using the internet to do everything, it can seem so simple, but really can be so complicated and be such a barrier for older populations.
Jacqueline?
I think just to build off what Rachel said, I think MGH and Mass General Brigham are trying to do some various initiatives to help with this. One of them is they worked really hard to streamline the process of adding an interpreter into a virtual visit. So it was a little bit clunky about a year ago now, but they've really worked hard to make sure that it is as seamless as can be to really not interfere with non-English speaking patients having a virtual visit. We've also developed multilingual patient education resources, from videos to guides about, you know, when is a virtual visit appropriate, what can you do to prepare, how do you download the program, really, really detailed in a few different languages. And then lastly, there was a small pilot, the MGH tablet program that it is currently in process, where they did lend tablets out to about 25 behavioral health patients. And along with that tablet, there was also a bilingual student intern who was available to help the patients access their email, enroll in the patient portal for Mass General, and then download and navigate the Zoom platform. So results, I think, are still pending on that pilot program. But you know, the hope would be that we could expand that to additional patients across Massachusetts, and not just to behavioral health patients, but to span further than that as well.
Meredith, Caitlin?
I was going to comment a similar program that one of the community sites I referenced, being the board member of Arthritis Patient Services, got some grant funding last year for the purchase of, I forget how many grand pads. And they were partnering, and those outcomes are pending as well, but they have partnered or distributed those through to, I think it's maybe 20 or 30 older adults served by Arthritis Patient Services, so they can access educational materials, respond to email or whatever mechanism of check-in that the staff at Arthritis Patient Services are implementing for those particular individuals, as well as some of the Zoom activities. So they've been well received, but I'm not sure yet because they're still collecting data as far as outcomes for those folks. But that's another example in the community of trying to make available the technology to the folks who need it.
Caitlin, anything you want to add?
Sure. I think one great change is in Rhode Island, I believe every district has been able to provide a device to every K through 12 child. So we do have now families that have much more access to technology because of that. So that's been a wonderful change for those families that did not have access to a computer or a tablet that can now access. And that's been a COVID change, as was there was some of the local internet providers provided free internet access to families, which I'm not sure if that's still ongoing, but that also provided more access.
That's great. That actually goes a long way toward answering one of my other questions, which is the role of various third parties in providing services. And I know I'm starting to hear stories from different places in the country of public libraries actually installing kiosks where patrons can come in and access not only the technology, but the privacy that they need to conduct visits if they don't have access. So aside from your insurance companies, of course, are there other third parties? And it may not be that they are helping, it may be third parties that are introducing challenges to the process. Jacqueline, do you have thoughts about that?
Sure. A few that come to mind. So again, interpreter services. So the hospitals, I think for the most part, do have a pool of interpreter services, but there are also outside companies that we work with to make sure that we can provide the breadth of languages that are needed for virtual visits at Mass General. And we've also seen schools really jump in for those that do have in-person days, and allowing families or patients to take their virtual visits from the schools. I think for a number of reasons, for access one, but also there are a lot of times school personnel, whether it's a teacher or the school nurse, a speech pathologist, where it's really beneficial for them to be involved in the virtual visit. So the schools have been huge.
Rachel?
I think Jacqueline really summed it up pretty well. I think the largest role for third parties, as she alluded to, is really assisting in with patients that have these special needs, like closed captioning services. And as you mentioned, Britta, just providing patients with a secure location to conduct their virtual visit from is huge. And, you know, there are opportunities at a lot of hospitals and healthcare settings to do that. But the more we can integrate that in many parts of the community, the more benefit is provided to the patient in terms of convenience. So I do expect that we'll see that continue to grow in the future.
I wonder, from Meredith and Caitlin, we really haven't talked much about Simmons, and I wonder if there are, you know, bodies within an institution like college or university that have a role in facilitating sort of one step removed in education, educational settings, if they have a role to play as well.
I think Meredith talked a little bit about our simulation software that we use, and I think that that's been very helpful. We use a program called Shadow Health, in which we have an avatar, and that's been very helpful in terms of providing their companies. And there's many, many more now over the past year that I think have built upon that. And
another thing that I've explored some, the comments I was making earlier about the limitations with the virtual psychiatric clinical patient via avatar was with a different technology. So like Caitlin says, I think they, you know, made advances, particularly over the past year, in making more realistic, as realistic can be, virtual clinical experiences. Shadow Health, which, as she said, Simmons uses, is one of the stronger ones that I would describe, having looked at, because I started investigating those with my first experience a year or so ago with the virtual clinical experience at a different institution. And so they do range in their authenticity, if you will. And Shadow Health is one of the better ones. But, you know, some of this is knowing, as an educator, knowing what's a good resource to use to teach your students to best equip them with the ability to practice telehealth.
Ongoing challenge, I'm sure. So I'm curious now to hear specific examples that you all have either experienced directly or heard about, anecdotes that show sort of the potential of telehealth for us. Meredith, do you want to start with that one?
Examples for the potential related to telehealth. Well, just recently, I received my COVID vaccination. So obviously I had to be on site, but it was really interesting and I was very impressed because telehealth was very much involved in my being able to get that vaccination because I had to complete the screening online in order to determine if it was my turn yet or not. Then I made my schedule. I scheduled my time for the pre and the post vaccination at the same time. I scheduled those and I was able to select a location. Then I got additional information emailed to me the day before. So I provided that information via the portal. So I was ready to go. And I was incredibly impressed with how that transpired when it was my turn to go for the vaccination. Because I drove up to the parking lot of our healthcare system in Charlotte-Mecklenburg, drove through. It was kind of like going to the bank. So although I did have some human contact, I just rolled down the window and pulled up my sleeve and got the injection. And then there was follow-up emails. How pleased were you with this visit? So it was really an interesting and a positive experience that utilized telehealth, but there was also that real person interaction and that touch involved as I got the injection. So that was a good example. I think this shows how telehealth can be nicely paired with healthcare as we know it.
Great. And congratulations on getting your vaccine. That's great news.
It's really,
I'm sure. Yeah. Rachel, do you have one to share?
Sure. So it's been really incredible to see the impact of our inpatient virtual care programs during COVID when we've had restrictions on visiting and over the iPad connection is really one of the main ways that patients who are hospitalized for COVID are able to see their loved ones. And a really special story that some of you may have seen in the news is that we were actually able to host 2 weddings at Mass General using our video conferencing devices when patients wouldn't have otherwise been able to be with their family members for that event. And we were able to have family attend over a video connection and really facilitate that whole process over video. That's incredibly special to be able to make that happen for these folks, and just shows the potential for technology to, at least incrementally make things a little bit easier, what we're all dealing with these days.
That's fantastic. Caitlin, do you have something to share?
Sure. I would say that I think that medication management has improved for me due to telehealth, as well as management of some of my patients that are struggling with various mental health diagnoses, because often patients will miss appointments, particularly if it's an adolescent that's struggling with anxiety and depression. They may have a hard time getting to the practice or get to the office. So if I can schedule a visit with them on the phone every 3 weeks, 4 weeks, that's been really a helpful change for me. And the same goes for long-term medication management. Someone that's coming every 3 months for years to manage their medication may end up missing appointments over time, where it's just a challenge to get into the office. So that's been very helpful for me because it's much easier for them to answer a phone call or do a virtual visit in the middle of the day. And I would say it's also been very helpful for parents that are working. Our late evening appointments tend to be the most popular because for working parents, but if we can check in with them during their work day, that's been very helpful, and parents really enjoy that.
Makes sense. Yeah. Jacqueline?
Sure. So we have a provider who gave some feedback recently. She's specifically is in an ADHD clinic, pediatric ADHD clinic, and she has found it really beneficial to have virtual visits, really outside of the COVID crisis. But she had mentioned that many of the ADHD medications only last 8 to 10 hours, and so oftentimes, especially for children that are in school, she wasn't able to see the patients during the hours that these medications are taking effect. And oftentimes, we all know how it can be to wait in a waiting office, the waiting office of the doctor. Children would often be agitated by the time it was time for the provider to actually see them. So the fact that she's able to see them in their home environment, typically usually when the medication is still being effective, and without that waiting period, which may agitate the patient, she has found it to be, really beneficial in her practice, and patients are much happier, and she's getting a lot more out of their visits.
Oh, that's also encouraging. We are right near the end of our hour. There are two things I want to make sure we hit on before we close, and maybe have a couple minutes for questions as well. One is, being a librarian, I feel it is my duty to ask if you can think of some good sources for information about telehealth, reliable sources, maybe beyond someone's doctor's office, that coming straight directly from the provider, but outside of that, that would be helpful to hear about. And then in terms of the future going forward, what you see as the next steps, especially as hopefully we start to get COVID under control. And I'm interested in circling back all the way to the beginning to talk about some issues like the HIPAA policies and the insurance coverage, and how whether those are sustainable. And also, the schools have made the idea of a hybrid model, sort of popularized that, and if there's talk about that within the medical field as well. So take your pick of those many questions. Meredith, do you want to start us off again?
Well, I was going to say, in thinking about my proposals that I wrote and submitted last year and one this year, in preparing for those, I became aware of several textbooks that are focused on nothing but telehealth skills, essential telehealth skills for practice, both at the basic level and the advanced practice nursing level. So I was pleased and kind of impressed that there are entire textbooks devoted to that. And I've started to find a number, and I would even classify to say there are growing numbers of websites with information ranging, from what is basic as what is telehealth nursing, providing a definition of what all telehealth nursing encompasses. And at the other end of the spectrum, more advanced information like specific tools one can use for documentation or prescribing. And I'm going to put some links to a couple of these sources that I was just describing in the chat box. But I think it's exciting, and there's a lot of possibility there. But certainly I would say, you have to use your judgment when you're assessing the quality of a source. But because with the increasing number of resources, some of them are not going to be as high quality as others. But if we know what to look for and what was best going to serve us and be a reliable and valid, credible source of information, there's a multitude of things out there.
Great, thank you. That's very helpful. Jacqueline, can I go to you next?
Yeah, absolutely. One website that comes to mind is the American Telemedicine Association website. It's ATA. I can put the link as well in the chat. But it's a source, that we use in the Center for Health quite often. A lot of good articles. It's just a really great resource for kind of, keeping up to speed of what's going on with telehealth. It's an ever-changing landscape. So, they do have a lot of helpful information there. I also think a really good resource for patients is their insurance provider, going to them and asking various questions of what's covered, what's not. A lot of insurance companies have, their own telemedicine platform that they use now. So I do think that is a good resource as well.
I'm sorry, Bridget, did you say my name?
Yeah, just wondering if you wanted to take on either of those remaining. Yeah,
absolutely, sure. So it will be really interesting to see the future of inpatient telehealth. We now have an iPad deployed to every bedside at MGH. So the potential for what these devices can do is, really unlimited. Think of what we could just do on our iPhones right now. But, serving as a way for patients to access educational materials on their diagnosis, kind of integrating with a patient record or my chart, and even serving as entertainment hubs for hospitalized patients can be beneficial. And so it'll be exciting to see how we continue to leverage the devices. In terms of the future of telehealth and the prevalence, I think it's really going to depend on how payment parity exists in the future. Right now, we're really only guaranteed until the end of the declared public health emergency, which is about another month or so. So we'll have to see what happens after that, and that's really going to be the determining factor in how much virtual care we're able to provide.
Thank you. That's really helpful. Caitlin?
I would say that I would be shocked if the hybrid model of outpatient medical care does not continue, assuming that payment continues from the insurance companies. And I do think it has been a wonderful change for healthcare. And if you asked me that maybe a year or two ago, I would say that I would never be comfortable practicing telehealth. And I think if you talk to some of even providers that have been providing care for many, many years, they would have said that, and now maybe their vision has changed. What I would love to see in terms of telehealth is improvement of the physical exam portion. I was listening to a podcast recently from a pulmonologist who was talking about doing home pulmonary function tests, which I thought was really neat for his asthmatic patients to manage that. So there are ways, there are some otoscopes that you can project the image onto the screen. So there are ways, and I'm sure that those are to come in the future, but that's the portion of telehealth that I would love to see improved upon.
Okay, thank you. We have one more question from the audience and then we will close. An attendee wonders, what views do the panelists have about telehealth providers like Amwell and Teladoc with whom health plans contract for virtual care? Anybody have thoughts on that?
I'd be happy to share my thoughts. We have obtained in our practice a patient-centered medical home designation, PCMH, which is a national designation that you can obtain. So I truly believe my philosophy in healthcare is that you should have a medical home and be able to access that. So I feel like the best place to go is to your primary care provider. Certainly I may be biased because that's what I do, but I have concerns about my patient accessing a provider that they've never met before and that does not know them well.
Anybody else?
I don't have any specific, experience with working with either of those, but I think I would agree with Caitlin, especially now in this post-COVID world, or hopefully once we get to that post-COVID world. I think pre-COVID, there were many often provider offices that didn't offer telehealth. And I think, those Amwells and Teladocs really were beneficial for if you couldn't get into an office. But I think now that so many folks are offering these services, I do agree, like sticking within your provider's services, whether it's specialty or primary care, is really beneficial for the patient and providers.
Okay, thank you for that question. Hopefully that answered it. And thank you all so much for being here this afternoon and for sharing your thoughts and your expertise. It's been wonderful to have you, and we look forward to working with you again in the future. Thanks everyone for coming.
Thank you.
Thank you.
Thank you. Bye.
Thanks for having us, Britta. I appreciate it.
Thank you so much. Thank you. We'll be in touch.